Mark, you want to move on to the next speaker?
Yes, I think we have to come on to the next speaker. We will speak about intraperitoneal chemotherapy, and we will go to Japan for that with one of the best TSSPP members from Japan. And thank you to be with us, because I think it's very late in Japan, and the pictures behind you is not the reality. I think it's completely dark now. So Hironori Ishigami is one of the best surgeons in the world from gastric cancer. Yeah. So we'll be happy to have your input regarding all that question. Thank you. Thank you to be with us.
It's okay?
Yes, yes.
Yeah, yes.
Nice, very nice heading.
Yeah, let me start. It's a bit late to say this, but Happy New Year to all my friends around the world. This is the year of Ox this year. Standing in Asia, standing for hardworking or gentle. I should be like them. I give a talk on intraperitoneal chemotherapy for gastric cancer. These are my topics today. First, IP chemotherapy for gastric cancer with peritoneal metastasis, P1. Next, gastrectomy after IP. And then IP for the prevention of metastasis, new trial. Peritoneal metastasis is the most important metastasis that we should conquer for our gastric cancer patients. The standard of care for gastric cancer with distant metastasis is systemic chemotherapy. This is the updated recommendation by the Japanese Gastric Cancer Association. First, 5-FU derivatives plus platinum, and then paclitaxel plus ramucirumab, and then nivo for the third line. Very different from the ones in the West, probably because we have more available drugs and more lines of chemotherapy. This is very, very well established, but it's too early to be satisfied with it, I think. For patients with peritoneal metastasis, it's necessary to combine powerful local treatments such as IP or surgery to prolong the survival of patients. Taxanes are ideal drugs for IP in terms of efficacy and safety. High concentration in the peritoneal cavity, minimal systemic toxicities, and no adhesion. However, the drug infiltrates only the surface of a peritoneal tumor and is not delivered to area with adhesions. So, IP should be repeated frequently with systemic chemotherapy. This is very important. This graph shows the pharmacokinetics of paclitaxel after IV plus IP administration. The intraperitoneal dose remained above this effective dose level for over 72 hours. In 2006, we formulated this Phoenix regimen, combining weekly IP paclitaxel with S1 paclitaxel. For IP, paclitaxel in a total of 1 liter of normal saline is administered through a pouch over 1 hour simultaneously with IV paclitaxel, usually in the outpatient setting. This is the overall treatment schedule. After IP port implantation, we repeat combination chemotherapy until curative resection is made achievable. When second-look laparoscopy reveals marked shrinkage of the peritoneal metastasis, we perform gastrectomy here. We restart chemotherapy as soon as possible, step by step like this, and continue it for no less than 2 years and taper gradually thereafter. We use this kind of port for IP administration. It is very important to suture and last the posture around the catheter tightly in order to prevent reflux from the peritoneal cavity to the subcutaneous space. Related to the IP port, we experience complications such as infection, catheter obstruction, leakage, or reflux in a total of 10 to 15 of the patients. Not very frequent and not very severe. I will show you a short video of laparoscopy before and after IP chemotherapy. You can see many nodules on the diaphragm and parietal peritoneum in the pelvic cavity. Here. and the mesentery as well. After 9 months of chemotherapy, peritoneal metastasis disappeared, nearly disappeared, leaving some fibrotic tissue behind. No cancer cells were detected by biopsy from around here. Please compare these pictures before and after IP. This is the effect of IP chemotherapy. Another patient, this momentum cake had reverted to normal after chemotherapy, and many nodules and the mesentery had almost disappeared. As you can see here, no adhesion of the catheter and no sclerosis of peritoneum after IP. In a phase 2 study, the MSD was 23 months at our hospital, despite that many patients had P3 metastasis. According to our previous classification, we have some 5 or 10-year survivors. In the Phoenix, phase 3, Phoenix DC3 trial, patients were randomized either to IP regimen or cisplatin, the standard in Japan, stratified by institution prior chemotherapy and peritoneal metastasis, P1 versus P23. Unfortunately, the primary endpoint was not met with a p-value of 0.08, despite a difference of 2.5 months in MSD and a hazard ratio of 0.72. After additional 1 year follow-up here, this survival went apart, and the 3-year OS rate was 22% in IP and 6% in SP. Six patients in SPR withdrew these trials and received IP elsewhere. Now, when we exclude these six patients, the MSD is 14.3, and p-value is 0.022. And we had a very crucial imbalance in the amount of ascites at enrollment. More patients in the IPM had more ascites. This resulted in favor of SP. When we adjust for the imbalance of ascites, the hazard ratio was 0.95, and the p-value is less than 0.01. This is a summary of the result. Also, the primary endpoint was not met. The sensitivity analysis suggests clinical efficacy of the IP regimen. We have developed several new combination regimens, such as S1 oxaliplatin plus IP paclitaxel at a higher dose, and capecitabine cisplatin plus IP docetaxel, aiming at a higher response. I will show you the results of clinical trials of these 3 new regimens. The patients in the Phoenix DC trials had more advanced metastasis and more ascites, but the Phoenix DC regimen seems the best in OS, contrary to our expectations, especially after 1 year. It's probably because of the long-term safety of the Phoenix regimen. This regimen was administered as much as 13 months, much more than the rest, because of less neurotoxicity and less gastrointestinal toxicity. Next, I will show you the result of subset analysis of pooled data of 222 patients from 3 clinical trials. By PCI, patients with PCI of no less than 20 here had significant worse OS, but an MSD of 12 months was better than the previous reports of the treatment. By the amount of ascites, patients without ascites had better OS, MSD over 20 months. Part 2 from here, as is shown here again, peritoneal metastasis can be controlled by long-term by IP. Meanwhile, the primary tumor is not controlled long-term by systemic chemotherapy. So I think it is effective to perform gastrectomy when patients show response in peritoneal metastasis. After confirmation of CY0 and no other distant metastasis, we perform second-look laparoscopy and proceed to gastrectomy when patient shows response in peritoneal metastasis. And then we perform gastrectomy when the tumor is resectable by standard or somewhat extended gastrectomy, excluding PG thoracotomy and peritoneectomy. I will show the result of retrospective study in P1 or CR1 patients with a primary tumor treated with IP regimen at our hospital between 2005 and 2015. Out of 158 patients, 98 patients showed remarkable clinical response, and the disappearance or shrinkage of peritoneal metastasis was confirmed in 95 patients, excluding one patient with TPOB tumor embedding the pancreas head, 94 patients, about 60% of the patients underwent radical gastrectomy. Many of the patients had P2 or P3 metastasis, both in patients with and without surgery. Naturally, patients without surgery had better OS, worse OS, and advanced metastasis. So the result of this arm are not comparable. Many patients received Phoenix regimen and some other regimens. Patients were administered chemotherapy for a median of 6 courses before surgery. The number of courses was determined considering the extent of the peritoneal metastasis and response to chemotherapy. Many of the patients underwent total gastrectomy, spleen, colon, and nets were resected in some cases. D2 or D2 minus number 10 dissection was performed in many cases. We performed complete D2 dissection like this in patients with minimal peritoneal metastasis or number 10 lymph node swelling. In patients with P2 or P3 metastasis or R2 as result, we basically omit splenectomy. Post-operative complications were acceptable. 65 of the patients had no residual tumor after surgery. A total of 47% of the patients had histological effect of grade 1B or more, which means viable tumor cells are less than 2/3. The MSD of patients with or without surgery was 31 or 12 months respectively. Also, these were not comparable because of the difference in the background and response to chemotherapy. The efficacy of surgery is strongly suggested by the huge difference. Next, I will show you the result. Oh, sorry. Next, I will show the result of subset analysis in patients with surgery. First, by the extent of peritoneal metastasis, P0C11, CY1, or P1 patient could be cured in some cases. Even patients with numerous metastasis, P3, could survive with an MSD more than 2 years. According to the R status, R0 patients had better OS, but even patients with R2 lived over 2 years. By histological response, good responders had better prognosis. Pathological end status is also one of the prognostic factors. N0 to 2 patients could live longer. The median relapse or progression-free survival was about 18 months. Recurrence was detected in the peritoneum in 61 patients. Some patients developed recurrence in the lymph node, liver, bone, and so on. So systemic chemo is also important in this population. This is a summary of the part 1 and 2. I think our data show the efficacy and safety of IP chemo and surgery after response. This slide shows what I think is important in IP chemotherapy: potency of the drugs, intraperitoneal concentration, duration of tumor exposure, depth of drug infiltration, and frequency and duration of treatment. This table compares 3 kinds of treatments based on my very personal opinion. HIPEC and PIPAC may have advantage in the depth of drug infiltration. On the other hand, our IP has an advantage in other factors. Paclitaxel is one of the most effective drugs for gastric cancer in monotherapy. The intraperitoneal concentration remains very high for long term, and the treatment is repeated weekly for months or years. Part 3 from here. On the very new trial we have just started to evaluate IP for the prevention of peritoneal metastasis. I will explain the standard of care in Japan first. For stage 2 and 3 patients, gastrectomy followed by adjuvant chemo is standard. Generally, SR monotherapy is given to stage 2 patients, and doublet regimens is doublet regimens to stage 3 patients based on the result of pivotal trials. How about NAC? The addition of neoadjuvant S1 cisplatin showed no benefits in type 4 large type 3 patients in Japan. In Korea, here, PFS was prolonged by neoadjuvant DOS, but no difference in OS. So NAC is still questionable when combined with tolerable and effective adjuvant chemo in Asia. For CY positive patients, the standard of care is yet to be established because we have no solid evidence in this population. Gastrectomy first is not so bad, MSD over 2 years, and many patients are treated by chemo first and some chemo only. We decided to perform a new trials in patients with type 4 tumor because the prognosis is poor due to a high incidence of peritoneal recurrence. Our new trial is performed to verify the superiority of combined IP and systemic chemo for type 4 gastric cancer. The primary endpoint is DFS. Secondary endpoints were OS safety and efficacy of preoperative chemo in CY1 cases. The eligibility criteria are type 4 tumor, clinical TC4, M0, P0, and macroscopic creative resection was performed in CY0 patients or seems possible in CY1 patients. This slide summarizes the standard of care for type 4 gastric cancer. CY0 patients are treated with gastrectomy followed by doublet chemotherapy regimen. S1 docetaxel is more widely used. CY1 patients are treated either gastrectomy first or chemo first. We discussed a lot and selected gastrectomy with perioperative chemotherapy for the reference arm. 3 courses of S1 oxaliplatin before surgery and S1 docetaxel after surgery. Paclitaxel is added here to the standard arm in the experimental arms. Here, docetaxel is replaced by paclitaxel. These are regarded as equivalent. These 2 IP arms are collectively compared with 2 systemic arms in survival analysis. These are regimens in the IP arms and the systemic arms. 300 patients are to be enrolled based on the assumptions shown here. The estimated hazard ratio is 0.64. To promote these trials, we set up 2 websites for patient enrollment and crowdfunding. We have already collected contributions as much as $300,000 US at this moment, thanks to the patients, doctors, graduates, and other people. We need much more, of course, and less needed to be paid by a hospital. Finally, I'd like to introduce and acknowledge the members of our study group from all over Japan. Thank you for your attention. Let's stay safe and healthy, everyone, and come to Japan someday.
Thank you, Ishigami.
Yeah.
Thank you.
Thank you. We have short times, but we have an interesting discussion, and thank you for the topic. It's amazing how many times you can treat the patient and control the disease.